Good morning to one and all. My name is Nick Garcia, and I'm a PhD student in rural sociology at The Ohio State University. This paper continues my research into disabilities with a particular focus on knowing places when discussing health outcomes, fitting this year's themes. I apologize for not being in Madison. That's my wife, and we are currently expecting our first child, so heading to Madison was not an option. Literally, our due date is this week, so if the audio cuts out, it may be because there's a new Garcia in the world. My paper begins by considering leading empirical research on disabilities, sociology of health, public health, health demography. These have all been tackling with two empirical trends that have defined the past several decades. The first trend is that working age adults have experienced noticeable increases in disability prevalence. Now, seemingly paradoxically, a second trend demonstrates declines in disabilities among older Americans, those aged 70 or older. Now, to explain why these aren't a paradox, the guiding theory invoked by researchers describing the trends, and more specifically their causes, involves what's called the disablement process. For Bruges from University of Michigan and Jets from Boston University, they founded this approach, and they have a wide sweeping appeal because, well, first of all, it's a pretty well organized and succinct commonsensical position. They suggest a four-stage model where individuals are introduced to some health risk. That yields a pathology, an impairment, and a functional limitation, which culminates in someone having a disability. So you can probably imagine a person living in a smog-filled area or someone exhibiting smoking behaviors. Those are health risks that are introduced where a person may develop a respiratory hardship. That hardship may cause an actual impairment that can culminate in inability to climb stairs or walk, so hence a disability is produced. You can probably see the multiple directions of the arrows because there are feedback loops where hardship in one area can also lead to more hardships in other areas. Now, when we apply this theory, this is how the empirical research goes. It applies the theory to address, well, first this trend. Declining disability prevalence among older adults is attributed to advances in technologies, things like prosthetics, surgical techniques, and education. I mean, there are falls prevention protocols adopted by hospitals and to do things to prevent seniors from falling and experiencing worse conditions. Now, that increasing prevalence of disabilities among older adults is attributed to, well, if you're wondering why I'm presenting a section that involves obesity, you can probably figure out what every article is referencing as the driving factor behind the increase in disability prevalence. Researchers point to a trajectory of obesity and disability prevalence at the national level and suggest that this surge in obesity is likely what's contributing to health risks that culminate in disabilities. It's actually rare to find research addressing increasing disability prevalence without invoking how the disablement process is being triggered by risks from obesity. Things like kidney impairment, cardiac health, and diabetes, these all contribute to limited mobility from exertion, but can also be linked to amputations or blindness, especially in the case of diabetes. And they tell a good story about how the trend lines do match up. But as I think about and reread the most prominently cited theory on empirical research, this disablement process article, I can't help but notice that part of their model is always missing in these publications. For Bruges and Jet, they claimed that the disablement process wasn't something that was merely the product of an individual's behavior. Instead, an important influence for how risk factors were introduced or how health interventions were coordinated rested in socio-environmental factors. Indeed, they say, so far the discussion implies that disability is a personal feature in the same way as age or occupation. In truth, disability is not inherent in a person. Instead, it denotes a relationship between a person and his or her environment. So, as a rural sociologist, I recognize the importance of place-based variables and the situation, the context in which people live their lives. So, I developed two research questions to revisit the disablement process with that socio-spatial component in mind. The first question asks whether there is a spatial component to measuring disability prevalence. It's a basic question among spatial analysts to look for clustering or dispersion across places to find whether variation is random or not. The second question asks if there is a spatial component, whether obesity is a pretty good predictor of disabilities. If the disablement process accounts are true, we should expect patterns where high prevalence of obesity is correlated with a higher prevalence of disabilities. I'm sad to say that I couldn't be in Madison because the University of Wisconsin, in collaboration with the Robert Wood Johnson Foundation, has made a very easy to navigate data set on obesity. The easiest way to access it is through their county health rankings. They combine behavioral risk factor surveillance system data with the National Health and Nutrition Examination Survey to use both interviews and physical examinations to establish obesity prevalence in every county, so we can actually do spatial analysis. The history of subnational disability statistics in the United States is horrifying. It wasn't until January of 2014 that we could actually say how many people in each county had a disability and what type of disability they had. The ACS's S1810 disability characteristics data set that looks at disability prevalence in each county according to age and disability type. And I can't rave about how great it is to be able to have this data set. Something I want to point out too is that a concern when culling disability data is that most people look for some kind of institutional measure, and these often come from like Social Security payouts and such, and that can lead to a lot of false identifications. Some people might be committing fraud where they claim a disability that they don't have, but the other problem is people not being able to be recognized as having a disability because they don't have a medical verification or a legal procedure where they can prove they have a disability. The ACS actually asks about whether people encounter serious difficulty hearing, seeing, or with cognitive function. And this is the standard that the WHO uses. And I'm glad that we're on board. So let's look at those questions. With those data sets in mind, a pretty simple way to answer the first question is to use that diagnostic in spatial statistics involving the calculation of a global Moran's eye. Now, the image on the right shows what that actually calculates. Basically, we're looking for whether there's a random distribution of obesity and disability across those places. So you would see high clustering in some areas, more than you would expect to be attributed to random chance alone in any place. And on the left, you'll see, well, you can look at the p-values on the left hand of the chart, and you can see that there's a statistically significant clustering of obesity and disability everywhere, except in the case of populations under 5. And this suggests two things. First, it means that the first research question of spatial components or explanations, it seems to be on point. Something's going on in the patterning of obesity and disabilities where the spatial distribution, it's not random. Something's happening in those areas which is producing these numbers. But second, it should be noted that this seems to give some sort of support for the disablement process more generally. We don't see patterns to disability until we start going through the life cycle and being exposed to risks and weathering. Now, the second question, that's really the million-dollar question, though, isn't it? This is where we find whether the talk of obesity as the driving cause of increasing disability prevalence is supported with these correlations. So to answer that, a localized Moran's eye, that's called a LISA statistic, actually maps where there is clustering of a given variable. Since many of you are addressing obesity prevalence, it's likely that you could have predicted this map. That Appalachian pattern is pretty clear here, with the south coast of the United States demonstrating high prevalence rates that are distinct from what we'd expect to see in a random county. So look at how Louisiana and Alabama are really high clusters. So if the prevailing application of the disablement process theory is accurate, we should expect those same areas where risks are so prominent to have similar clustering and disability prevalence compared to a randomly assigned place. And here's what we see. Well, I don't know what you think. I think we do see certain parts of Appalachia do, in fact, demonstrate clustering of disabilities. But what's going on in that south coast? I think we're actually seeing the opposite phenomenon that we might expect there. Rather than seeing a clustering of disabilities, well, that's where there's a low prevalence, a statistically significant low prevalence. But well, let's look at ACS lets us look at different groups, right? So let's look at under 5. Actually, let's not. Remember, our previous test said that it's not statistically significant in its patterning in the first place. And really, the weathering and the risks haven't kicked in yet. But as we look across different age groups, we see these groups are hinting at some Appalachian clustering, but they're very much contradicting what we'd expect to see in the South Coast in areas like Louisiana and Alabama. Something else that you should know about that South Coast is that not only is there a lot of clustering of obesity, but the counties with the highest obesity prevalence in the United States, they're right there in Louisiana and Alabama. And the intensity of obesity is pretty remarkable. So if you don't trust that LISA statistic, I should point out that a GETIS-ORD or a G statistic, generates hot spots and cold spots that can further explore these patterning phenomena. And what do we see? Basically the same thing we saw with the Lisa statistic. Obesity hotspots are in the South Coast and Appalachia, but even though there's some overlap in Appalachia, the obesity hotspots in the South Coast are cold spots for disabilities. Let's get specific here. Remember that the relationship between disability and obesity isn't general. We expect obesity to contribute to things like serious difficulties in mobility. So what's the mobility patterning look like? Well, it looks like all the other disability patterning that we've seen so far. And when we look at a specific disability outcome that might not result from obesity, let's say hearing loss, it just follows that disability patterning. It doesn't change much. So let's regroup and talk about what's been going on. I told you about the increasing prevalence of disabilities among working age adults. I told you that the leading papers are attributing this increase to obesity, invoking something called the disablement process, but they're not looking at it spatially. I showed you the research. There is a spatial component to the distribution of obesity and of disabilities, but when we look at the map, the support that we're seeing is for only parts of Appalachia, including parts of Ohio and the Carolinas, and we're finding the opposite distribution that we'd expect on the South Coast. I want to point out that there are benefits to an aspatial analysis. The way to really get at a causation story will certainly involve longitudinal data sets that trace individuals before and after having disability status. And that's not something that the ACS data will give us. But so far, it's come at the cost of excluding the consideration of environmental factors to just look at obesity. I make no claims that obesity doesn't contribute to disabilities, but the spatial patterning of these trends suggests that maybe we should try to incorporate spatial components that ask us to know the places where disabilities are high or low. There is a reason to believe that places have a role in explaining disabilities. And within rural sociology, there is a precedent for place-based distribution of health patterning. There's excellent work by Lois Wright Morton or Glasgow and Johnson in 2004 or Ricketts in 2000 that talk about things like healthcare infrastructure, availability of hospitals or preventative care or rehabilitation facilities. It's not a good thing when people have to drive across multiple counties in order to seek treatment. Then there are issues of rural employment. The idea of receiving healthcare benefits, well, that isn't something that was typical among the rural labor sectors. We saw that in both Glasgow and we saw that with Lebeo's work. But then there's regional health behaviors, things like smoking. And Singh has studied this, where we've seen that the drop-off in smoking rates has not been experienced in rural areas so much. And of course, there's another elephant in the room involving environmental justice that Mohai had pointed out in 2009. All of these are place-based determinants that introduce risks and hardships while also cutting people off from healthcare interventions. They're all a part of the rural sociological history, but they're not being integrated into the public health and public epidemiological discourse. So moving forward, I advocate for exploring disability prevalence rates, but reminding ourselves that we should incorporate place-based variations in anything from healthcare benefits to health behaviors to environmental quality and even accessibility of healthcare infrastructure. Without that, a fixation on just national prevalence rates outside of these contexts will allow us to conjure up stories, but they'll go unchecked on a national level. All right, that's it from me. Thank you so much. If you do have questions or if you want to further discuss this with me, please contact me. I love talking to people at RSS. It really saddens me that I'm not there to discuss this with you. But my email address is right there. It's garcia.119@osu.edu, and I'd love to hear from you. Thank you.